Wonderful. All right. Okay, good morning, and thank you for attending our Grand Rounds lecture. I'm pleased to introduce to you our dear speaker, Dr. Laurence Sperling. Dr. Sperling is a distinguished cardiologist recognized globally for his contributions to preventive cardiology. As the founder and former director of the Heart Disease Prevention Center at Emory University and current Katz professor in preventive cardiology, Dr. Sperling has been a pioneer in cardiovascular prevention. He directed the CDC-CMS Million Hearts Initiative, served as president of the American Society for Preventive Cardiology, and contributed to landmark guidelines, including the 2018 ACC-AHA blood cholesterol guideline. He's a leader in integrating cardiovascular care for high-risk populations. He chairs the World Heart Federation Roadmap for Cardiovascular Disease Prevention in Diabetes and directs Georgia's only LDL apheresis program. His numerous accolades include the American Society for Preventive Cardiology Pioneer in Prevention Award, National Lipid Association Lifetime Achievement Award, and over 450 publications. Dr. Sperling's impactful career in education, research, and public health continues to set new benchmarks in preventive cardiology. We are grateful for Dr. Sperling's expertise on this topic and look forward to learning from him. At the end of the lecture, we will leave time for questions. Please submit questions via the chat function on Zoom as they arise during the talk. We are pleased to offer both CME and MOC credit for our Grand Rounds Conference series. To claim credit for today's session, text the code shown. It's coming in the few slides at the beginning, at the end of this presentation to number which will be provided for you. For questions or logging into your Cloud CME account, visit vcu.cloud-cme.com or contact Shannon Winston. I will now turn it over to you, Dr. Sperling. We'll look forward to learning from you.
Well, Dr. Qureshi, thank you so much for the kind introduction. And I want to thank Shannon for all of her help getting me to the Grand Rounds today. I'm so sorry I'm not there in person. I really wish I could be, as there are Emory and VCU connections. What I'll be speaking about this morning is a focus on CKMH to prevent CVD. Now that sounds like word salad, but by the end of my presentation, you're going to be very familiar with the AHA's Cardiovascular-Kidney-Metabolic Health Initiative, the new Prevent Risk Calculator. In fact, we're going to walk together through how to use the Prevent Risk Calculator so you can implement this in your daily care of patients. I have no conflicts related to my presentation today. Well, this is just your secret code. So this is what you'll want to text or put into the system so you can get credit for my Grand Rounds this morning. And I'll come back to this, by the way, at the end of my presentation, just as a reminder. An outline of my presentation is as follows. I'm going to start out giving you a little bit of a sense of my journey, my family's journey, my professional journey. And I was asked to do this a couple of months ago. I gave medicine Grand Rounds at Emory, and they specifically asked me to give some personal information to start off because they wanted to have our trainees understand that we all have a journey. And we truly do. So get to know one another, you know, not just as this is the heart failure expert, the EP expert, the preventive cardiology doctor, but we have very unique backgrounds that bring us together at this moment, and we should appreciate that. So I'll start out with a little bit about my journey, a case. So we're going to start with a case that I do want you to take a couple of screenshots of, because we'll come back to that case, walk through the Prevent Risk Calculator together. Then an overview about this topic, the CKMH initiative itself, and then the Prevent Risk Calculator. So a little bit about my journey. As I said, we all have unique backgrounds, and I'm only the second generation in this country on my dad's side of the family. And my grandfather came from a little village on the bank of the Dniester River, which is in the Ukraine. I was very fortunate to visit there about a decade ago, and you know, at the present time, because of the situation, wouldn't be able to visit there. My mother's family came from a town in Lithuania, so third generation there. So a very interesting history related to my family. In fact, my father's brothers, he was the youngest, but his older brother was born in Romania, the middle brother in Canada, and my dad was the youngest, so he was born in Brooklyn, New York, which is how I became a New Yorker when I started out my youthhood. And my journey in cardiovascular disease prevention, I think each and every one of us have a motivation of why we're cardiologists. My grandfather on my mother's side of the family had a heart attack at a young age in his 40s. He was told he needed heart surgery, but at the time there was no bypass surgery. He was turned down by some of the leading experts, Denton Cooley and others. And eventually Walton Lillehei, who invented the heart-lung machine, did a procedure on my grandfather called the Weinberg procedure. So you can look that up. But there's some physiological plausibility for the Weinberg procedure, implanting the left internal mammary artery into the myocardium. But my grandfather still died at a young age, and it really impacted me as a teenager that people we love that mean a lot to us and our families can be affected by heart disease. And I would wager that the majority of us have had people in our families affected by heart disease, as are others in this country and around the world. Well, I've been at Emory for many, many years, a great institution in Atlanta. I do want to point out two things about Emory. In the lower left-hand corner here is, as we get older and start developing gray hair, the joy of our careers are getting to help mentor others, watch them on their career paths as well. So Dr. Anurag Mehta has been such a special person for me to work with, first as a fellow, now as as one of our leaders in cardiovascular disease prevention in a very short time. And we truly consider Anurag a member of our extended family. So I know he's been a gem there at VCU. The other thing I'm going to point out is in the upper right-hand corner, that's the Emory basketball team. And if you look at number 23, that was me in college. I played college basketball. So if you're wondering why Michael Jordan and LeBron James picked number 23 for their uniform, now you know. I didn't make the NBA draft, so my backup plan was to become a cardiologist. And you should be aware that the Emory Eagles are the #1 ranked team right now for Division III in the country. So, and of course you don't hear about them because they're not Duke or UNC but for Division III, Emory Eagles are ranked #1 right now. For all of you, whatever stage you are in your career, my career has evolved not by design. I often use a quote by Yogi Berra, who had been the catcher for the New York Yankees. And he said, when you come to a fork in the road, take it. There are many opportunities in life, and we often have to think about, the challenges of new career paths, of course, the angst of new career paths, but also the possibility for impact. And so my career started out in molecular and vascular biology, and not by design. I very much now work in the spaces of prevention, of course, but population health, global health, and public health. And I truly have been fortunate to stand on the shoulders of giants at Emory. I trained with Dr. Willis Hurst, so I hope you all are familiar with Hurst the Heart. And Dr. Hurst had been a great influence on me. In the lower left-hand corner is Nanette Wenger, who Nanette has been such an influence globally on many, and a mentor for myself and others. And then in the middle bottom panel is Keith Churchwell. Keith was my chief resident, and Keith is now the president of the American Heart Association. It's the 100th anniversary of the AHA. as mentioned in the introductions, up until a couple of months ago, I served our nation as the executive director of the CDC CMS Million Hearts Initiative. This initiative is something I do want you to be familiar with. It was launched in 2011 with appropriations from Congress. This initiative is focused on the possibility of preventing 1 million heart attacks, strokes, and cardiac events in our nation through implementing proven and effective strategies across all states by building healthy communities, optimizing care through what we call the ABCs, and then a core focus on health equity. So please look at cdc.gov, Million Hearts at cdc.gov for additional information. Well, we all have superpowers. I often say that my superpower is I've been able to surround myself with superheroes. Our two sons in the center, my wife, Dr. Sydney Barr, who I met in the medical school library, and she's an Emory faculty member as well in internal medicine. So now we'll move to a case. I mentioned that I grew up in New York. Well, I met my wife now of 33 years in the medical school library, and she's from a very small town in Southwest Georgia. So I do want you to take a screenshot of the next two slides, because we're coming back to this case and we're going to walk through the prevent risk calculator together. So this is a 59-year-old female postal worker from Cuthbert, Georgia. And I know there are many small towns in Virginia as well. Population less than 3,000. The zip code is relevant for the prevent risk calculator, 39840. She has cardiac risk, hypertension, diabetes, dyslipidemia. She's recognized her risk, so she's trying to walk more, trying to eat better. She had gestational diabetes and preeclampsia during her pregnancies. Her primary care doc's been treating her blood pressure, her cholesterol, and her diabetes with medications. Blood pressure is 148/88, BMI 35. I actually still use a stethoscope. Dr. Mehta will verify that. So I heard an S4 gallop on exam. GFR 54, urine albumin creatinine ratio of 100. This is something most cardiologists don't measure, but we need to, and we'll talk about why. Total cholesterol 196, HDL 34, triglycerides 220, LDL of 118, A1C of 8.4%. So we asked the question, what is this woman's 10-year and now 30-year risk for total CVD, ASCVD, and heart failure? So we're coming back to this. As an overview, cardiovascular disease has been the #1 cause of death, the leading cause of death in our nation for over 100 years, except for 2 years. These were the 2 years of the Spanish influenza pandemic, 1918 and 1920. There have been racial and ethnic disparities persisting in cardiovascular disease and cardiovascular deaths. And we celebrated about a 50% decline in heart disease and stroke mortality from about 1960 as a peak to 2010. But in 2010, these curves flattened, and now we're heading in the wrong direction. And in 2/3 of the counties of the United States, we are seeing earlier events. So in younger people, we're seeing heart attacks and strokes. I know I see this at Emory University Hospital. I'm sure you see this in your own hospital. Well, I am involved with global health as well. I work with the World Heart Federation, and over the past 3 decades, the global burden of disease has radically changed, and heart disease, ischemic heart disease, has snuck up on us as the leading cause of death in now what is called very much a global economy and highly relevant. This is a figure from a recent paper in JAMA, and it points out, if you look at the leading causes of death from 2019 to 2023, in the midst of a global COVID-19 pandemic, there are 3 things I want to point out. One is, if you look at the top of the figure in mustard yellow, heart disease, even in the midst of the COVID pandemic, remained the #1 cause of death. Now, thankfully, the black curve here, COVID-19, deaths have dropped. But if we look at stroke in the green, stroke has risen from the 5th cause of death to the fourth cause of death in our country. Well, way back in 1961, before I was born, with just 2 words, Dr. William Cannell helped to change our understanding of the underlying causes of heart disease and stroke. He was director of the Framingham Heart Study. And with these 2 words, the field of preventive cardiology was born. And so I'm going to ask those on the call here for Grand Rounds what these 2 words were. And I know you're familiar with these 2 words because we use these every day when we get to meet our patients and ask them, do they have cardiac risk factors, whether it's primary prevention or secondary prevention? And we know now that these risk factors, the traditional risk factors, are the core of risk, but we've gone beyond traditional risk factors, understanding now what are called risk-enhancing factors. But we know that many, many things affect our cardiac risk. In fact, epigenomics, our environment, particle pollution. So we are more sophisticated in understanding risk and addressing risk. Well, what do we think about using risk scores, or why should we be using risk scores when we care for our patients? And we should think about risk not just in primary prevention, but at Emory, one of our big pushes is focusing on better understanding risk for secondary prevention. Well, risk scores are a way to efficiently identify those at higher risk who need more preventive-based treatments. And way back to the 27th Bethesda Conference, we still think today that the intensity of treatment should match a person's risk. We also know that physicians or clinicians are not very good at guesstimating risk. In fact, we're very poor at it. It's like a scattergram or throwing darts. But ultimately, the reason for risk scores are they should lead to a greater use of guideline-directed medical therapies and improvement of quality of care and outcomes. Back in 2013, the guideline on risk assessment or assessment of risk pointed out that preventive cardiology efforts, but I guess I would emphasize that all of our cardiology efforts, whether you're seeing a heart failure patient, an EP patient, an adult congenital patient, should begin with an assessment of risk. I hope you've become familiar with the risk estimator and risk estimator plus, the ACC-AHA risk estimator. This has been out there now for about a decade and has been the tool that we should think about using for risk assessment in primary prevention. When we risk assess, we want to ideally have strong calibration for a population we're assessing risk in. And we also want to be able to discriminate risk, those who are lower risk, intermediate risk, or higher risk. So those terms, calibration and discrimination, are important. But of course, with any risk tool, we will overestimate risk in some and then underestimate risk in others. The metabolic syndrome is a very common entity, and by definition, this is the WHO definition, we think about the presence of visceral adiposity or central obesity as a tenet of the metabolic syndrome. But there are 5 criteria, and in order to have the metabolic syndrome, by definition, you need 3 out of 5 of these: modest hypertriglyceridemia, low HDL, elevated blood pressure, and an elevated fasting plasma glucose. Now, we have patients with metabolic syndrome who we are caring for all the time, and we often miss this diagnosis. They're told you have pre-diabetes or mildly elevated blood pressure, or your cholesterol, needs some work. But it's important to call out this diagnosis, because I frequently in tandem talk about heart disease and diabetes prevention. But as you'll see with the CKMH initiative, it goes way beyond. A decade ago, we brought forth the very first cardiometabolic think tank. We hosted over 20 organizations at the ACC's Heart House, and we published this paper in JACC called the Cardiometabolic Health Alliance, working towards a new care model for the metabolic syndrome. We were the first to describe stages of metabolic risk. Stage A, at risk. This can be genetic. It can be related to socio-demographic factors, gene environment, behavioral interactions. Stage B, you're beginning to develop the metabolic syndrome, but not yet by definition. Stage C, you have this syndrome. And then stage D, there's end organ damage. And so on an individual level, but also a population level, we should be matching our therapeutic approaches with stages of risk. We also pointed out a decade ago the importance of integrating care, partnership, and broadening our stakeholders to go beyond clinical medicine, including public health and the community. We also described subtypes of the metabolic syndrome, and I still think we don't fully understand why one patient develops, fatty liver disease, another patient develops polycystic ovarian syndrome, but many of our patients have several of the manifestations or subtypes of metabolic syndrome at the same time, an overlap or a clustering. We published this paper in JACC in 2019, looking at what we call then non-alcoholic fatty liver disease, now MASLD. But if you look at our central illustration and how complex the pathophysiology of NAFLD or MASLD is, and you also look at the changes in signaling, vascular biology, endothelial dysfunction, oxidative stress, inflammation, it looks quite familiar because this is the same pathophysiology of atherosclerosis, and these are intimately related. Well, the metabolic syndrome, and as we move into CKM syndrome or disease, is a gene environment behavior interaction. These genes are very common, present in anywhere from 1/3 to over 1/2 of populations. We talk about metabolic susceptibility and a clustering of metabolic risk factors. This paper we published in JACC described the health disease continuum, and as cardiovascular specialists, we often are encountering disease way to the right here, right? The red box, disease that's unfolded, it's late in the stages, but it's really important that we dial back to the left-hand side of this figure, the green box, the light green box. We want to understand what it means to focus on health promotion and disease prevention. Well, we describe Atlanta as the city too busy to hate, the home of Martin Luther King Jr. His base church was Ebenezer Baptist Church. And in 1966, Dr. King was quoted as saying, "Of all the forms of inequality, injustice in health is the most shocking and inhumane." In the circulation paper, we described the importance of what we now call social drivers of health, not determinants. They're not necessarily predetermined, but as opposed to traditional risk factors, access to care and healthy foods, people live in areas of food insecurity, psychosocial, behavioral, and environmental factors are not only equally important in determining risk. For many of our patients, they are bigger determinants, and we need other strategies beyond just guideline-based care and lifestyle modification to address them. Well, of course, we want to prevent diabetes. This is a slide from the DPP, the Diabetes Prevention Program, a seminal study. And in this study, those with pre-diabetes, 3,400 were randomized to usual care, metformin, or a lifestyle approach, walking 30 minutes 5 times a week, healthy dietary pattern, losing at least 7% of the body weight and maintaining it. And you can see over 5 years that the lifestyle approach was twice as effective as metformin. And so it's critically important we think about prevention of diabetes, which is very much related to the prevention of vascular disease itself. This is a figure from the ticking clock hypothesis, and we should think about this gene-environment behavioral interaction as one that can be suppressed, but once the clock starts ticking or the switch gets flipped on in terms of changes in signaling, the clock starts ticking. And we see this happening in 8-year-old children silently until there's development of risk factors and ultimately overt disease. And we'll come back to the ticking clock hypothesis towards the end of my presentation because I'll talk about a paper that was published in JACC just 2 weeks ago, and my companion editorial. In this circulation paper, it was an AHA scientific statement about the need for comprehensive management of risk factors in adults living with type 2 diabetes. We point out the need for integrated care, comprehensive risk reduction, and then at the bottom of the figure, bringing in not only awareness of social drivers of health, but being able to address these in populations, individuals, and families. Well, now the CKMH initiative. One of our star fellows, Alex Razavi and Roger Blumenthal at Hopkins, published this position paper recently to remind us that we have a changing risk factor landscape, increase in BMI, pre-diabetes, but longer life expectancy, although the last number of years we've actually lost our gains in life expectancy. Changes in trends in cardiovascular outcomes, more patients with heart failure with preserved ejection fraction, decrease in type 1 MI, but we have more tools in our toolbox today, and we should clearly be focusing on the importance of care across the lifespan, and that vascular disease is very much a head-to-toe proposition. The AHA launched the CKMH initiative. I'm grateful that I was part of the team launching the initiative and also the team that derived and validated the Prevent Risk Calculator. If we want to really hit at the heart of the CKM syndrome, it's all about interconnectedness. We unintentionally develop silos in health and healthcare and even health delivery as we think about silos between clinical medicine, public health, public policy. Well, the CKM syndrome is a health disorder due to connections among heart disease, kidney disease, diabetes, and obesity, leading to poor health outcomes. But we know now that this syndrome affects, dementia, macrovascular disease, microvascular disease. The pathophysiology is related to ectopic fat, so visceral adiposity, often hidden fat, changes in signaling, oxidative stress, insulin resistance, vascular dysfunction, the development of risk factors over time, and the impact silently on microvascular, macrovascular disease, and ultimately outcomes. Well, this has really become a pandemic and an epidemic in our country. CKM syndrome is increasing. In the CKM initiative by AHA, they mirrored our description of stages as opposed to ABCD. These are now stages 0 to 4. Unfortunately, most Americans do not have stage 0. This is no risk factors. And stage 4 is you have end organ involvement. In this letter in JACC this year, we pointed out that most adult Americans, even young Americans, those ages 20 to 44, 80% of them have stage 1 to 3 CKM, and only 2% of Americans over age 65 have no CKM syndrome. Well, we should always be thinking about our patients, our families, our communities related to a socio-ecological framework. We live within our local environments, but more so our community environments and now our societal and global environments as we think about potential solutions. The ACC in 2020, at the time, we published this expert consensus decision pathway on what we described as novel therapies for cardiovascular risk reduction in those with type 2 diabetes. Well, now just 4 years later, the SGLT2 inhibitors are not novel. We feel very comfortable as cardiologists prescribing these. And the data on the GLP-1 receptor agonists it's really incredible, the compendium of data. And now with the SELECT trial, we know that those who have ASCVD with obesity without type 2 diabetes will have a cardiovascular risk reduction of 20%. So the GLP-1 receptor agonists are not just weight loss drugs, but they're drugs for cardiovascular risk reduction. And the CKM syndrome, in the CKM initiative papers by AHA, there's a description of a presidential advisory, 2 scientific statements, a paper where we derived and validated the Prevent risk calculator. These papers go into mechanisms, gaps, need for screening, and prevention and management through each of these stages. Because of time, I won't be able to go through each of these, but these are important tools and references for all. So I gave you an overview. Now you know what CKMH stands for. More importantly, you understand the burden of this. I do want you to think about when you're seeing patients today, whether in the clinic or the hospital or the cath lab, the CCU, whatnot, you'll start realizing how many of our patients have CKM disease. And we should always ask the why question. Why have our patients arrived in the cath lab? Why are they having a PCI or bypass surgery? Well, now the Prevent risk calculator, I come back to the 2013 guideline that says prevention begins with assessment of risk. And whether you're aware or not, we use what's called the C statistic, an ROC curve, plotting 1 minus specificity versus sensitivity. So the line of chance is it's a purple line across the middle. This is like flipping a coin. The red curve might be the Framingham risk score or the pool cohort equation. And hopefully the dotted yellow line in the upper left of the curve is now the Prevent risk calculator, trying to get to better ability to discriminate and also calibrate in a population. Well, whenever we develop a risk tool, we know that risk estimation is based on group averages. We try to apply these to individual patients. So this process will always be imperfect, and we need to recognize this. In this, this was a paper we published in parallel to the 2018 cholesterol guidelines, a paper about risk assessment tools to guide decision-making in primary prevention of ASCVD. And Donald Lloyd Jones, who is at Northwestern, but is about to move back to be the new director of the Framingham program in Boston, he described this as CPR. So we want to focus on CPR with our patients so we don't have to do CPR later on in their care. So we calculate risk, we personalize risk, and then we should think about reclassifying risk. Beyond the traditional risk factors, we described a term in 2018 called risk-enhancing factors as part of the clinician-patient risk discussion. And you can see on this list is the metabolic syndrome, CKD, chronic inflammatory diseases, pregnancy-related conditions, and then also high-race ethnicities like South Asian ancestry. Not to say we should be measuring these in all of our patients, but if you have a high CRP, elevated ApoB, and Lp(a), which we should think about in many of our patients because 1 out of every 5 people are living with a high lipoprotein(a). After you calculate risk, you get a 10-year ASCVD risk, 4 buckets, low, borderline, intermediate, or high. And I'll remind you that the threshold for thinking about statins when these risk assessment tools were developed, it's about 7.5%, but we know that the net clinical benefit for statins and some other therapies might even be as low as 3%. Clinician risk discussion with our patients. If there's uncertainty, we try to reclassify risk with other tools or markers such as cardiac CT calcium scoring. The Prevent risk calculator, Prevent stands for predicting risk of CVD events. I talked about derivation, validation. What's most important though is the implication of the new Prevent risk calculator, and critically important is implementation, which is what we're going to do together shortly. Well, this was published in JAMA right after we published our paper about Prevent. What to know about Prevent? Well, Prevent allows a 10 and 30-year risk assessment, starting at age 30 up to age 79, calculating total CVD risk, ASCVD risk, heart failure risk, incorporating markers of kidney and metabolic diseases, in this risk tool, race and ethnicity was eliminated. And this was not a political statement. This was a scientific statement that by using zip code as a surrogate for the social deprivation index, this was a more impactful risk tool. The Prevent Risk Calculator was based in terms of derivation on over 6 million individuals from cohorts and real-world data sets. And the goal is to be able to embed this in our electronic records for ease of use. Well, we talked about social drivers of health. We know that our zip code where we live is a more potent predictor of risk than our genetic code. This is a map of Atlanta. It's actually a slide that I got from a VCU site, but we know that health is local, disease is local, and in Atlanta, I imagine similar to other cities around our nation, we know that life expectancy in even a short distance in Atlanta, within a 5-mile distance between Buckhead in the northern part of the city and Bankhead in the southwestern part of the city, is at least 14 years or greater. And the majority of that is related to cardiovascular death and health disparity. The social deprivation index includes markers of poverty, education, housing, transportation, and unemployment. Well, now it's time to get your iPhones out, or if you have a computer in front of you, you can bookmark. So just search AHA Prevent Calculator. So I'm giving you 30 seconds to do that. So bring up your Prevent Risk Calculator. There are many elements of the risk calculator that you're going to be familiar with because they're the same traditional risk factors you've been imputing into the pool cohort equation. But now beyond that, we will add if our patient's on a lipid-lowering medicine, if they have data on a urine albumin creatinine ratio and A1C or zip code. Most of our patients, we're going to have a zip code. You know, it's right on their chart. We can put this into the risk calculator. So now we're coming back to the case. I asked you to get a screenshot earlier, but you can take a screenshot here. And let's start putting this data in. 59-year-old female, zip codes 39840, hypertension, diabetes, and dyslipidemia. You can see she has risk-enhancing factors. This won't go into the calculator, but we should be aware of those risk-enhancing factors: gestational diabetes and preeclampsia. On medicines for blood pressure, cholesterol, and diabetes. Systolic blood pressure 148, BMI 35, eGFR 54, urine albumin creatinine ratio of 100. And this is a pretty simple study that we can order for our patients. Total cholesterol 196, HDL 34, A1C 8.4. The calculator will allow you to step through a risk 10-year and 30-year of total CVD, ASCVD, and heart failure. And you should get these numbers. And you can take a screenshot here. And if you want, come back to it. But you can see the 10-year risk is quite high. We typically say, you know, a 20-year, 10-year risk is like a risk equivalent, you know, somebody who already has overt disease. And you can see the 30-year risk is quite concerning, even though this patient with known risk factors is already being treated with medications for hypertension, hypercholesterolemia, and diabetes. Well, what should our goal be? For our patients, it should be to take a patient on the blue trajectory curve and bring them down to the green, reducing absolute risk through relative risk reduction over time, because cardiovascular risk exerts its influence over time. This is like an integral in calculus, an area under that curve. Well, the CKMH initiative, or the CKM initiative by AHA, is off to the races. There will be a separate CKM guideline committee And right now, the Hypertension Guideline Committee is meeting. The new Lipid Guideline Committee is convening. But the AHA and beyond, because this will be a guideline of the AHA, the ACC, and other specialties, to develop an online calculator. So that's already happened. You have it bookmarked, and I would challenge you to use this Prevent Risk Calculator this week with at least one or more patients. Ideally, this should be embedded within our electronic record, and our electronic record should calculate the risk for us to help us think about therapies, not just statins, but other therapies that we know can reduce cardiovascular and vascular risk. And with this tool, hopefully improve equity in CVD prevention. Many people were involved in the CKM initiative and Prevent risk calculator development. But now we come back to assessing risk, that CPR, calculating risk, personalizing risk, and reclassifying risk. We should be able to do that for our patients. And we should also identify the stages of risk, CKM risk, whether stage 0, which is infrequent, all the way to stage 4. Well, I pointed out that every risk calculator, just by definition, will be imperfect. But there were papers that raised questions about the Prevent Risk Calculator. This one splashed very big in the news and raised the question, would the Prevent Risk Calculator actually prevent the use of statins or blood pressure medicines? And in this paper, the authors used data from NHANES. They used the 10-year ASCVD risk, compared pool cohort and prevent. They used that 7.5% threshold and said that 14 million individuals would no longer be recommended for statins or blood pressure medicines, and that theoretically there'd be more heart attacks or strokes. Well, I said, don't press the panic button on prevent. And there were 2 great editorials written about this paper. First of all, the paper didn't evaluate the full prevent equation. It only looked at ASCVD risk, not total CVD or heart failure, didn't look at risk enhancing factors, and didn't take into account that prevent has greater ability to discriminate and calibrate. And also the paper didn't think about that, we likely will think about lower risk thresholds for other medicines in prevention in the future. In care in general, we need not to be the blind men with the elephant. We can't just be focused on our specialties or subspecialties. We need integrated care. We talk about team-based care. We actually need to implement team-based care. This was a great paper that talked about precision prevention, bringing together precision medicine and precision public health through using data at our fingertips, AI, which I call augmented intelligence or assisted intelligence, not artificial, because we will always need HI, human intelligence. But here we should bring together the clinical world, public health, public policy at the community. In this commentary in JACC, Valentin Fuster pointed out that cardiometabolic diseases have emerged as the biggest threat to human health in our lifetime. Microvascular and macrovascular concerns. We need both leadership, but also we need to flex our focus from a shift in sick care to preventive care. I work with the World Heart Federation. I'm co-chairing a new initiative that we're calling multiple metabolic long-term conditions and integrated care, and developing a roadmap with people involved from 5 or 6 continents as experts. Well, now as I begin to conclude, this is a paper published in JACC just 2 weeks ago from a Danish registry, case cohort data 127,000. And in this paper, the authors looked at this registry data, the index of incidence of diabetes, and they looked back 3 decades and then 5 years forward. And the main finding was that 3 decades before the diagnosis of diabetes, cardiovascular event rates were doubled. And these findings have really important clinical health system and public health implications. And I wrote this editorial along with this paper, and I came back to talk about the ticking clock hypothesis, cause for concern or window of opportunity. Well, actually both, clearly a cause for concern, but also a window of opportunity. So as the clock starts ticking, then gene environment behavioral interaction, visceral adiposity, insulin resistance, change in signaling from a molecular and vascular standpoint, clustering of risk factors, we need approaches that are systems-based approaches, integrated approaches across the life course, changes in public health infrastructure, policy focus, and community integration, because we need to tackle the root causes and complex contributing factors. So I started off with CKMH to prevent CVD. You're now familiar with the CKMH initiative across the life course. Lack of CKMH is unfortunately common and concerning. You now know about the Prevent Risk Calculator, and you're ready to use this today and beyond with your patients to be able to prevent ASCVD, CVD, and heart failure. We should always remember risk assessment as a starting point and that we need comprehensive and integrated CVD prevention. And clearly, the CKM initiative and the Prevent Risk Calculator will likely be important parts of future guidelines. So I come back to your code for CME credit. So text this number to the phone number there. Your code will expire in 48 hours. Truly appreciate you all inviting me to give this grand rounds. Really honored and grateful. I wish I was there in person, but you do want to get credit for my grand rounds. So with that, I'll conclude. Thank you so much. Glad to take some questions or comments. I'm going to stop sharing, and there we go.
Well, thank you so much. Yeah, thank you so much, Dr. Sperling. That was a fantastic talk. We truly enjoy it. I will ask our audience to put their questions in the chat box so I can read it for Dr. Sperling. I'm going to go ahead and start my own question. I have 2 questions. My first question is, how often in your practice you use calcium score to further risk stratify your patient? How much it's practical in using day-to-day practice, especially in the clinic when you are seeing your patients?
Yeah, so great question about cardiac CT calcium scoring. I was the second physician in the state of Georgia. When I was a fellow, I was trained in cardiac CT. This was way back in 1997. There were only 4 cardiac CT scanners in the world at the time. It was a 4-slice EBCT scanner. So we, of course, have better tools today, but cardiac CT calcium scoring is really our best tool for risk reclassification, but it needs to be used appropriately. And so best used in those at either low risk or low to intermediate risk or intermediate risk with often a family history. And when we're on the fence about thinking about risk, going through that CPR, that's the risk reclassification. So you can use sometimes a calcium score of 0 to de-risk patients, although 0 doesn't mean no atherosclerosis. It means no calcified atherosclerosis. Atherosclerosis develops over time, the timeline of atherosclerosis. But often you will find somebody with a calcium score that can be really important in terms of understanding their risk and risk reduction strategy. And we always think about the calcium score related to age, gender, and ethnicity. And it is an important tool. The AHA right now, I'm vice chairing a scientific statement that will focus on the pragmatic use of general CT of the chest, because now we know through using machine learning AI algorithms, we can go into a whole health system like Emory or VCU. We know there are 18 million CTs of the chest done every year in our country. And we often, do those for many other reasons, right? Lung cancer screening, somebody with chest pain, whatnot, lung nodules. Well, it's important we extract the evidence of subclinical atherosclerosis from that CT, like we can also extract from a CT of the belly or other tools. We're also working on a project related to BAC, breast arterial calcification, which is more medial calcification, but a marker of cardiovascular risk. So great question. We use cardiac CT calcium scoring often. A frequent question I get, I was asked this in clinic yesterday by two patients. You know, they had evidence of subclinical athero, and their question was, should I have another cardiac CT calcium score? And my answer is no, because we can't decalcify, but over time, the calcium score will go up with a greater slope in those who are treating aggressively. It doesn't mean the disease is getting worse. It's actually taking soft plaque, creating heel plaque, fibrotic plaque. So that's my answer there. Definitely want to be sure I answer other questions that are there from the audience.
Sure. Thank you so much. All right. I have a question from Dr. Butner. She's asking, thank you for a fantastic talk. You highlighted the importance of social drivers of the health, which is included in the preventive calculator. How can we as providers influence drivers of health captured by zip code?
Yeah, so really, really important question. So first of all, you know, not a fan of the term providers. I refer to health professionals or clinicians or physicians. Whenever I am editing a paper or looking at a presentation, I am very intentional about doing that. And there are very specific reasons I do so. CMS is requiring that we gather this data. So we will be required to gather the data on social drivers of health with our patients in the electronic record. That's a starting point, but clearly it's just a beginning. So what can we do? First of all, you know, we often feel unempowered to do something to help our patients. And this is where, I mean, we can do things to help guide our patients to either resources or having discussions about transportation challenges and or just how to navigate areas of food insecurity. So this begins with that clinician-patient risk discussion, establishing safety and trust. I wrote an editorial in Jack many years ago, and it was titled Safety and Trust Beyond All Else. But we need systems approaches. We need to realize from systems levels that these are not just things we want to talk about, but things we actually want to do something about. And we need our leaders to prioritize this. We need our systems to invest in it. But we can't do this as healthcare systems in isolation, because if we focus only on the ability of healthcare systems to address health, we're really addressing only about 20% of health and disease. So we need connections with community, policy, public health. And this is where our nation falls the shortest compared to other industrialized nations. We have very sophisticated abilities to deliver healthcare, which is actually disease care, but we underinvest in the programs that are really important to population health.
Thank you so much. I guess I have time for my second question as well. One of the biggest challenges that we face in our daily practice, especially with our patient, we talk about the preventive cardiology. We talk about all the risk factors with our patients, about the diet, about the risk, about the medication. But I think the most challenging, at least for me, is it's very difficult to engage the patients in this process. What will be your approach to turn this around and you make your patients more adherence to your recommendations?
Well, of course, it's all about engagement of the patient, right? It's that trusted clinician-patient not just risk discussion, but it's developing a true relationship over time. And we, I think in medical school, we're starting to do a better job of teaching our students about behavioral science. But this is all about not just, understanding data and pharmacotherapies, but behavioral science is learning about single concept learning, readiness to change, setting realistic expectations over time, and then also the term self-efficacy. And so, the usual discussion with a patient is Mr. or Mrs. Smith or Brown, you're at risk for heart disease or you have heart disease. So let's focus on stopping smoking, exercising more, eating better, losing weight. Here are some handouts, and we'll see you back in 6 months. Well, that is not how we are successful. So we need to learn from our patients where they see their capacity to begin to make change and start with one area of focus. This takes time, but very rewarding, very successful. We talk about non-adherence in patients. We often say, oh, you're not taking your medicines. Well, I see Dave Dixon's joined. Dave was an author on a paper where we talked about clinical or therapeutic inertia. That's the flip side. We really want to think about optimizing care, but we also can't meet a patient and prescribe 7 medicines at the first visit. This has to be a stepwise process. So it is essential. And then we need team-based care. We clearly need clinical pharmacists as part of our team, medical assistants, nurses, nurse practitioners, but we also need unique ways of delivering care like telehealth and telemedicine, which 90% of our care was telehealth or telemedicine at the peak of the pandemic. Now it's 5%. We are really just beginning to understand the ability to deliver telehealth and telemedicine with strategy and intent. And why should somebody who has transportation issues have to figure out how to, drive 45 minutes to wait in the waiting room for a 15 or 30-minute visit? We need to understand who we need to see in the office, but there are many patients we can focus on care delivery when they're at home.
Well, fantastic. Thank you so much. I guess we have only 3 minutes, and I have time for the very last question here. It's from Dr. Dahal. He's one of our cardiology fellow with the great background of the cardiac imaging. He's asking, we can do CT angiogram and classify different types of plaques. So moving beyond calcium score, what is your opinion about therapy based on plaque characterization by CT angiogram?
Sure. I mean, we of course will always have better and better technology. Science is charging ahead. Our true gaps are not in guidelines or science. They're in implementation science. So clearly, CTA, plaque characterization, we can do CTA with FFR. I mean, these are great tools. Now, are these the tools we need to reclassify risk in primary prevention? I don't think so. We need to still think about CPR. A non-contrast cardiac CT is still a very valuable tool. I think still for the right patient, a CTA plaque characterization is important. We learn a lot, but when we start finding vulnerable plaques in vulnerable patients who live in vulnerable families and vulnerable communities, we need to extend our care in many, many different directions. And, many of our patients have vulnerable plaques that come and go. We're certainly not going to stent those plaques. So we're really treating a systemic disease, a comprehensive disease, and a disease that affects the entire body, not just the coronary arteries.
Wonderful, amazing. Thank you so much, Dr. Sperling, for your time. With that, we conclude the sessions of Grand Round. I hope you all enjoy your holidays and happy weekend. All right. Thank you.
Yeah, thank you again. So appreciate the opportunity to join all of you today.
Thank you.
Thank
Bye.
you so much, Dr. Sperling. Have a great holiday too.
Thank you.